I'm Monty, Editor-in-Chief of TopMedTalk, coming to you live from Anesthesiology 2018, the annual Congress of the American Society of Anesthesiology in San Francisco, USA. I'm lucky enough at the moment to be sitting right at the top of the Hilton Hotel in Union Square in their rooftop bar where they're preparing for this evening, hence the music playing in the background, looking out over a magnificent view of San Francisco Bay. We've been lucky enough just to secure an interview with Professor Henrik Kehlet, who will be joining us shortly, along with my co-host and associate editor of TopMedTalk and lead for the USA, Desiree Chappell. TopMedTalk. So we've now been joined by a very special guest, Professor Henrik Kehlet, best known as a professor of surgery from Copenhagen in Denmark, and often referred to as the inventor, which we'll come back to, of fast-track surgery or enhanced recovery. So, Professor Kehlet, Henrik, if I may, tell me a little bit about your current role.
The current role, in my opinion, is facilitate implementation of enhanced recovery, but much more to try to make progress and change the focus from length of stay to what happens after discharge and safety.
And you think despite all the developments in enhanced recovery that safety is still a major concern?
Yeah, because we know that every major operation is followed by a risk of complications. So we haven't achieved what was from the beginning the aim to have a pain and risk-free operation. I would be terribly afraid if I was going to have a major operation, knowing all what can happen after surgery.
So you mentioned right from the beginning, we've known each other for coming on for decades now, and the first articles that I can find with your name against what is interpreted as enhanced recovery is a review article in the British Journal of Anesthesia from about 20 years ago, and then a review article in the British Medical Journal from about 2001. What got you going? Why did you start to shake this whole thing up as a surgeon?
I was interested in the classical endocrine metabolic response to surgery from the beginning, and asked the question, why is the patient in the hospital? Why is it dangerous? And of course, the first problem was pain management, and we solved that 30 years ago. And everybody expected patients to jump out of bed and go home, but it didn't happen. So then you had to ask again, why was the patient in hospital? And then it turns out that you have 15 different factors determining the outcome. And realizing that you cannot solve the problem by a intervention. You have to have a multimodal intervention.
So just to be clear on that, you're saying as much as 30 years ago we worked out how to take the pain away and keep the pain away. But despite making surgery virtually pain-free or pain-free enough, people weren't still jumping out of bed and going home, which, as you say, when you think about it, you think, well, what's keeping them there?
Because of traditions in care. I mean, nobody thought about the importance of early mobilization to decrease thromboembolic complications and pulmonary complications. Nurses thought that, the patients are pain-free, that's great. And so what?
So the big advantage of being pain-free is that you can then get people going again. Is that right? Get them up and about.
Yeah, I would say that sufficient pain management is a prerequisite to enhanced recovery, but it's not enough.
So, could you expand on that a little bit then? What else do we need to do? That's a big question, but the big ticket items.
The basic problem is the surgical stress response, where I think the classical endocrine metabolic response, we have more or less solved that by regional techniques, minimally invasive surgery, etc. But we still have these inflammatory responses that influence every organ in the body. And recent data here from San Francisco, from Stanford, have shown that recovery is dependent on the individual patient's magnitude of the inflammatory response. Clearly documenting that the way forward is to find those patients and try to reduce it. But there are many other factors. There's blood management. In the last 5 to 10 years has appeared as a very important thing. But again, we lack data on post-discharge things. Sleep disturbances, cognitive dysfunction, fluid management, as we have been discussing for decades. So there are all these factors you have to control.
So now the results that you've presented with regards to managing patients in this way have always been very, very impressive. And I think it's fair to say that anyone who's tried it, as we have at the table here, myself, Desiree, other people, and tried it properly, you realise the results. They are very, very impressive. There's been talk about the fact, and I think it's justified, that this is one of the greatest contributions to modern medical care of patients. And there's even been talk about Nobel Prizes, which I think is an appropriate discussion. I don't want you to get into that. That's all embarrassing, I say. But what I do want to do is to touch on whether this is becoming a standard around the world. And I know, Desiree, you've got a question about that because you were in a meeting yesterday where you heard Henrik talk about this.
Yeah. So you gave the pioneer lecture at the American Society for Enhanced Recovery meeting yesterday here at the ASA, and it was entitled Past, Present, and Future of Enhanced Recovery. And so we have a pretty good understanding of what you've been doing and what what's happened in the past. But from your experience in your own organization and as you travel around the world and talk to people, how do you feel enhanced recovery has been adopted? I mean, do you think the uptake is there, that people are finally starting to do this, or it's a standard of care?
It has been quite disappointing, despite all the scientific data to show that you get these results. But it's improving. I think it's a curve that is really going upwards, adopted much more, but we are far from reaching standard of care, far from reaching that. I think also we are far from understanding that the concept can also be and should also be applied to medical patients. But internists, they have been very slow to understand these possibilities.
Well, let's hope it doesn't take them 20 years to come around. But as far as, actually trying to implement enhanced recovery, I read a paper that you did with Vijay Gautam about the challenges of enhanced recovery adoption and what some of those are. How do you think we can overcome those? And what do you see on the ground right now when you travel?
It depends on the local discussion. I mean, when I go to China, the Chinese system is totally different. If the professor says, we do it, they do it. Yesterday we had a discussion here in US, and it's very complicated in US, the health system, because there's too much anarchy. Every surgeon is his own king. It's really difficult to have this team approach, as we all agree about. So it depends on the local traditions.
Those silos of care can be the ultimate barrier, for sure. One of the things you touched on in your lecture yesterday as well was the fact that when enhanced recovery first was coming out back in the early 2000s, you would see this infographic of all these different elements, 20 to 30 different elements. And one thing that struck me yesterday when you were talking was the fact that maybe we should just simplify things, and that would help actually help with implementation and adoption.
Definitely. I mean, when we started in colonic surgery, I think we published the first paper in 95 in Lancet. There was only 5 elements of care. But now it's expanded in the guidelines to 24 elements. And obviously, they are not all that important. And the problem is that if you go out to a place to want to initiate enhanced recovery and you give them a scheme with 24 elements, you will get a lot of resistance because it's too complicated. So it has to be simple and pragmatic, and the key elements, and again, it has to be on a procedure-specific basis, because in some operations it can be even fewer, and in some it may be a little more, but never 24.
So, Henrik, what are the 5 then?
Depends on the operation, but if we talk about colonic surgery, it's preoperative information, it's the fluid management, avoiding hypovolemia and fluid excess, it's early mobilization, and early oral feeding.
And the pain management.
And pain management, of course.
On that, when I look back again at the original article that I read, just on reflection, it's that final box. The one unifying factor is this early drinking, eating, mobilizing, hopefully sleeping, etc., which is often referred to as dream or dreams now. Now, as we get into that and do it, that is also not as easy as one might think, is that we certainly in our institution, as we do more and more complex major surgical procedures with enhanced recovery, we see orthostatic hypotension that was probably there before, but it's not quite clear what we do to avoid it. We see in some patients, in some procedures, GI tract dysfunction that seems to be hard to avoid. And as we're increasingly aware of sleeping, a lot of patients are telling us they don't sleep well. Are there any unifying factors here?
I'm glad you bring it up because this is my interest about the pathophysiology of recovery. And we have neglected all that because we are discussing implementation all the time instead of how to understand the recovery process. Now we come back to the inflammatory responses, which I think are responsible for all these events you are talking about. We have known for at least 20 years that after major surgery you have severe change in your sleep. REM sleep completely disappears on the first night and it can last for a few days and come back with a tremendous sympathetic response, which is dangerous for the heart. Orthostatic intolerance. I'm surprised that so few people have looked at it. We have published quite a number of papers. It's depending on the magnitude of the operation. So again, we come back to the inflammatory responses. It's a peculiar change from sympathetic activity. When you stand up, it disappears in about half of the patients. So the parasympathetic nervous system takes over. We don't know why, but that's the ongoing studies. And also we are focusing on reducing these inflammatory responses by high-dose steroids preoperatively, hopefully to get away from the sleep disturbances and the orthostatic problems.
It sounds as though, even though many people are pushed away from small mechanistic studies, is we need to go back to doing a lot of that basic science and understanding the pathophysiology.
I totally agree. I don't think that these huge pragmatic RCTs done in a non-evidence-based program will help us with progress. And the problem is that all these trials are mostly negative.
So I think that was spontaneous applause from the background because we're actually on the rooftop of a hotel where they're doing some abseiling off the building. But let's soak it up. So thank you. But thanks, folks, for agreeing with that. And if any large trialists are listening, don't take it personally. It's not that the whole of San Francisco agrees, but there we go. That was a beautiful moment. So inflammation is the recurring theme here, and almost everything we look at, it's the magnitude of inflammatory response, including possibly a driver of dementia, possibly a driver of post-operative cognitive dysfunction. It's all a recurring theme.
Yeah, I think with regard to cognitive dysfunction, I mean, we have two types, early delirium and late cognitive dysfunction. The early delirium, that we can avoid by a fully implemented enhanced recovery program. Early return to their home environment, opioid reduction, etc. But the late cognitive dysfunction is more difficult. I think we really don't know what it is, except it's again according to experimental studies, also here from Stanford, it's an neuroinflammatory reaction.
We're coming close to the end of our time. We want to just look to the future for a second. And back to you, Desiree, again. You picked up on this, I think, in the lecture yesterday that sadly I wasn't at.
Yeah, there were a couple points. I think the inflammatory response is huge, and there's definitely future research there. A couple of the things you were talking about, ward monitoring and remote monitoring, utilizing technology in practice. I think people get a little excited whenever we talk about tech in practice. But and then I also want you to touch on patient-reported outcomes.
As I said from the beginning, my focus is now not so much on length of stay, but on what happens after discharge, because we call it enhanced recovery, but they haven't recovered. They're able to go home. So I think we have to focus on that period, and there are two ways to do it. Patient-reported outcomes, which is a subjective assessment of recovery, versus using new technology to objectively assess what they are doing and what they can do. And of course, I'm a firm believer of the last one, because studies have shown there is a discrepancy that patients can be happy on the patient-reported outcomes, but when you assess their actual function, they cannot do it. So what is most important? That they are happy or that they haven't recovered? I think we need a lot of studies to look at the physical recovery in different organs post-operative. And that includes, of course, the cognitive issues, but especially muscle function and cardiovascular adaptation to exercise, etc.
And in that, do you think the remote monitoring that the youngsters are using now to track their personal training, wearables, big data sets, use of artificial intelligence, is that all rapidly coming into play?
I wouldn't say it's rapidly coming into play.
As quickly as enhanced recovery.
But it's coming into play because that's the way forward. To collect those data and integrate them together. Yeah.
So if you had one take-home message, I'm doing this recently, if we gave you a billboard and you could put a big message up on it for people getting started in enhanced recovery, would you have any simple first message for them?
Yeah, ask the question, what are the factors responsible for not recovering? Is it pain or whatever it can be? And then you go and try to modify it and see the results.
So fix what's holding back your patients. Yep. So Professor Henrik Kehlet, if I may, the father of enhanced recovery, recorded here live at Anesthesiology 2018 in San Francisco. I believe you got out I know you've been working almost continuously since you arrived and you're leaving, but I think you did have a couple of hours off. What did you do in the few hours off?
I think I went over there to the Sausalito with the ferry. Same sunshine, fantastic. Seafood in the restaurant, and in the evening I went to the opera and here Tosca.
And how was Tosca?
That was fantastic. Very traditional setting, but the singers, the music, conductor was fabulous. Recommendable.
Fantastic. Well, Professor Henrik Kehlet, the Hilton Hotel here, who very kindly let us in. The activity in the background of people abseiling off the building there, which is looking quite exciting. And Desiree Chappell, co-host, thank you very much indeed.
TopMedTalk. Thank you.